The following podcast is part of a certified educational activity titled Landmarks Across the Patient Journey in AML, Applying Evidence with Novel Therapeutics Pre- and Post-Allo HCT. Access the entire activity and complete the post-test at peerview.com/HJG860. Downloadable slides and practice aids are also available.
Good morning, everybody, and welcome. We'll start this symposium. My name is James Ford, and my co-chair is Dr. Uma Barate. I'm from Mayo Clinic in Jacksonville, Florida, and Dr. Barate is from the Ohio State University. It's the Ohio State University, Cancer Center. And welcome to our symposium on landmarks across the patient journey in acute myeloid leukemia, applying evidence with novel therapeutics pre- and post-allogeneic transplant. So since 2017, we have, after a long period of time, finally have some developments in acute myeloid leukemia and some steps forward. We've seen the FDA approvals of liposomal daunorubicin cytarabine, of FLT3 inhibitors midostaurin and gilteritinib in different settings. Actually, quizartinib, another one, is approved in Japan. The IDH inhibitors, the reemergence of gemtuzumab, venetoclax, oral azacitidine maintenance, which we'll touch on, and also glasdegib. We want to center on emerging advances that validate novel targeted doublets or triplets, moving the field forward, developing strategies for challenging subgroups, and also confirming the role for immunotherapy beyond allogeneic transplant in acute myeloid leukemia, and how will these all be used in conjunction with transplant. These are some presentations that were at ASH last year. Despite a wealth of innovative options, more work really needs to be done to actually bring these therapies to patients. In real-world data, looking at a comprehensive health system in the Midwest in the last decade, from 2011 to 2018, you could see that 66% of patients over the age of 75 did not receive any therapy for acute myeloid leukemia, so that remains a need. Only about 1 in 8 had evidence of a genomic report, despite the fact that this has been used for prognosis, in some cases for a decade, for FLT3 testing at least. Also, when looking at EMR data from over 2,000 patients to look at the impact of COVID-19, compared with the pre-COVID era, post-COVID patients were significantly less likely to receive allogeneic transplant, and there are longer transplant waiting times, suggesting that the pandemic has affected the access to timely transplant. So this is an area of need for us also, to actually get more patients to transplant, to have more genomic testing, and to really get more older patients therapy. So we're going to go through mapping pre-transplant treatment decisions with novel targeted and other treatment platforms, and Dr. Barate is going to give this part of the presentation.
Thank you so much, Dr. Foran. It's really great to be here with colleagues, especially Dr. Foran, who I trained under in fellowship. I still remember his clinic notes and how he always mentioned the patient's pets and what they liked in terms of food choices. So I'm going to start off with our choices in FLT3 mutated AML. And let's start with the case because we all see patients and this is sort of how we change our practice. So this is Mark. He's a 66-year-old patient with new AML. He has a FLT3 ITD mutation. He has a high white count. Really no major comorbid illnesses. His ECOG is fairly good. And let's talk about how we approach treating Mark based on the data. So I think we're all very familiar with the NCCN guidelines in a patient like Mark who's Mark who may be less than 60, who's fit, and is a candidate for induction. And the guidelines typically say that in these patients, you want to induce them with standard chemotherapy with a FLT3 inhibitor, namely midostaurin. And then you have other options for patients that have unfavorable risks or therapy-related AML and so on. So specifically for Mark's case in FLT3 mutated AML, the first indication, or the first line indication is standard dose induction with midostaurin. And let's look at kind of how we got there and why we do this. And this is also for the case of patients greater than 60 who are fit for induction. And so I think, again, all of us are very familiar with the RATIFY study. This study looked at standard induction chemotherapy in patients with FLT3 mutations. Unlike Mark, the trial looked at patients 18 to 59 years old, and patients were either randomized to get midostaurin with induction or placebo, followed by the same thing in consolidation. You could go to an allostem cell transplant if needed, but was not required by the study. And then there was a maintenance portion, which Dr. Foran will talk about in a little bit. And as you can see on this slide, patients really did do better when they had FLT3-directed therapy with midostaurin, but the benefit was especially seen in patients who received a transplant in CR1. And you can see if they received a transplant outside of CR1, that benefit was not sustained. So as Dr. Foran mentioned, midostaurin is now not the only sort of FLT3 inhibitor on the block in frontline therapy. We recently had a press release about data from the Quantum First study that it has met its primary endpoint in overall survival with a very similar patient population and a similar study design, where it was combined with standard induction and consolidation and improved overall survival. We do not still have data from this study to show, but this is something we expect to see, and this may be another option for our frontline patients as well. So emerging combinations that I think we're all excited about, we're all familiar with using gilteritinib in the relapsed refractory setting and some other situations which we'll talk about. And this is some data looking at upfront gilteritinib when combined with chemotherapy. And this study sort of summarizes the results of the dose escalation and the dose expansion cohorts, looking at a dose of 120 milligrams daily when combined with different standard induction regimens. And in this study, patients really did have a sustained duration of response, a pretty comparable disease-free survival, and the overall survival has not been reached. In terms of AEs, when these FLT3 inhibitors, specifically for this trial, when gilteritinib is combined with 7 and 3, there's not really that much more toxicity compared to what we see with 7 and 3 alone, with obvious things like febrile neutropenia really being the big grade 3 and higher toxicity that we all are fairly used to managing in this type of induction therapy combination. So I think these are some of the exciting upfront comparison studies that we're really looking forward to. The first one I want to mention is being done by PRECOG. This is comparing the standard of care therapy currently, which is 7 plus 3 plus midostaurin, with 7 plus 3 plus gilteritinib in a design that's fairly similar to the RATIFY study. The accrual goal is 179 patients. The study is actively accruing, and I think we're quite excited to see data from this study because I think there's a lot of discussion and data now that while midostaurin was a good choice at that point when the trial was performed, it's not as potent of a FLT3 inhibitor as some of these sort of second generation inhibitors. So it'll be interesting to see a head-to-head comparison and what that looks like. Similarly, there is a phase 3 study looking at CPX-351 in combination with gilteritinib in a younger patient population that's fit for induction, and also a phase 3 study looking at midostaurin, comparing it to crenolanib, which is another FLT3 inhibitor in a similar situation, is also recruiting. So let's talk about the situation where you don't have this perfect fit patient that you just go straight to induction and you sort of have your path laid out. And I think a lot of us in our clinical practice do see patients that are not fit for induction, that are older, that then we treat with, which is what is now considered the standard of care for our older, unfit, newly diagnosed AML population, which is HMA plus VEN, based on the VIALE-A data, looking at its efficacy in this older population. Now, looking specifically at patients that had FLT3 mutations, overall, these patients did benefit from the AZA-VEN combination compared to AZA plus placebo. But if you sort of compare their responses to, let's say, the IDH mutant group or the NPM1 mutant group, they didn't do quite as well as those subgroups of patients. So I think we all do feel that there is some room, or in fact, maybe more than some room to improve in terms of HMA plus VEN for a FLT3 mutated older patient. This is obviously standard of care, and there's nothing wrong with using this regimen. I think we all use it in our older AML population, but as we'll talk about, we really want to see what else we can offer these patients. So going back to looking at the VIALE-A data and how many patients actually proceeded to stem cell transplant, well, about 10% of patients that got a response, which is a CR, CRI, or CRH, actually did go on to receive a stem cell transplant. You can imagine that these are older, unfit patients who are not really considered transplant eligible. So I think it was really remarkable that even 10% of them had a response, typically between the first couple of cycles, and then went on to a stem cell transplant. And this data sort of shows how those patients did post-allo transplant when they were able to go to transplant. Their 12-month overall survival was 84%, which I think is very good for that patient population. So just something to keep in mind when you have your older patients, it is very possible if they respond to think about a transplant referral and offer them transplant. So moving on to something that was alluded in the first question that you guys responded to, is there a role for novel upfront strategies? And I think this is something that we're all excited about. There was a lot of conversation and data presented at ASH. And the first presentation that I think got a lot of discussion was looking at the combination of aza-ven plus gilteritinib and how that could potentially improve response rates in patients with FLT3 AML. And this was a study which looked at relapsed refractory AML, high-risk MDS-CMML, as well as newly diagnosed FLT3 AML. And they showed that this triplet was highly effective with almost 100% composite remission rate in the front-line setting especially. But I think what was notable in this study is they really were very aware of the combined cytopenias that can occur with this combination. So instead of the traditional approach where you do a marrow at day 21 to day 28, they actually did a day 14 marrow and stopped therapy early, especially with venetoclax, if they felt that the patient had a response. So I think this tells us that as the field moves forward, we have to be very careful in how we dose these triplets and sort of manage the toxicities with the efficacy that we hope to see. And the gilteritinib dose that was deemed effective and safe was 80 milligrams as opposed to the 120 milligrams in the relapse setting. So another abstract that was presented was a retrospective look at all of these doublets and triplets, and it did show or seem to suggest that this approach may be very effective in FLT3 AML. However, at the same ASH meeting, you also saw results of the LACE-WING study, which showed that the frontline combination of aza plus gilt versus aza alone actually did not reach its primary endpoint. And did not show a survival benefit. There were a lot of flaws, I think, with the study design, but I think that is something to remember as well. So I want to sort of throw it back to the group and Dr. Foran and just ask, now that we know about this patient, we've reviewed the data, I think with the patient fitness, the current evidence, I think there is support for frontline induction therapy with the FLT3 inhibitor by all the different data that we just discussed. But as you guys indicated in your preference, could a novel triplet be considered if Mark was unfit? Would you give Ven HMA? So some questions, Dr. Foran, for you and for discussion.
Yeah, no, thanks. I mean, in our institution, we would have followed an intensive therapy strategy. I really like that ratified transplant outcome curve at 70% is among the best that's been reported in that setting. And a triplet, I know there's a lot of enthusiasm for it. It certainly makes sense, but I think that's also a harder therapy. And so I think in an unfit patient, there'd be a question mark, and a fitter patient would certainly make sense if you had some reason not to give an anthracycline, for instance. So, yeah, that data is very interesting.
Completely agree.
Yeah.
So I'll turn it over to you for the next one.
Thank you. Thanks. So what are the next steps in FLT3 AML? And we have our patient Mark, who we just talked about, who went on to a FLT3 inhibitor, midostaurin in this case, with intensive chemotherapy, went into remission, had a matched donor, went on to allogeneic transplant. And what are our post-transplant maintenance options for this patient who had a FLT3 ITD? Well, the original study was the RATIFY study that allowed maintenance midostaurin versus placebo after complete remission. It wasn't really designed to show a difference in this setting, so this was an outcome just looking at what happened to those patients at the end of therapy. There was really no statistical difference between continuation of midostaurin for a year versus placebo for a year in terms of disease-free survival. But again, the study wasn't really designed to answer a detailed question about maintenance like that. So it's not really, it's not negative data, it's just negative data. I think the innovation, the publication in 2020 of the SOAR-MAIN study of sorafenib versus placebo for a patient with a FLT3 ITD who had had an allogeneic transplant really has changed our perspective. And so this is a small randomized study. There were only 83 patients on this trial. But you can see in the curve on the left, the relapse-free survival, the curve on the right, the overall survival, a significant reduction in the hazard ratio for patients who got randomized to sorafenib I think it was for 24 months versus placebo after allogeneic transplant. And so that hazard ratio is 0.39, so 61% reduction in the risk of relapse. Similarly, on the right, the hazard ratio is 0.51, so almost a 49% reduction in the risk of death at any time point of getting maintenance sorafenib versus placebo. Now, it's a small randomized phase 2 study. Sorafenib is not on label in the United States. It's not FDA approved for this. Actually, I've tried to prescribe it in this setting. It's not always approved, but it does tell us that there's an important role for FLT3 inhibitors in this setting. And the trial that we're anxiously awaiting results from is the BMT-CTN 1506 trial, or the MORPHO trial, which was randomized of gilteritinib versus placebo, a much larger trial. And the question in this post-transplant FLT3 ITD positive patient population in first remission is there a benefit to FLT3 inhibition with gilteritinib? This is using an NGS-based MRD assay for FLT3 ITD mutations. And the first question is, does the detection of a FLT3 mutation predict relapse? And the second is, does a FLT3 inhibitor prevent, when the MRD assay detects relapse, is that meaningful? And so we're waiting for results of the MORPHO trial, and hopefully we'll have them, I think, possibly this year, to help us really know, is gilteritinib a better therapy in this situation and an available therapy in this situation, at least in the United States. And so our patient, Mark, who went on to transplant, unfortunately has a relapse 2 years after transplant. This is a situation that happens in I had 3 patients have 2-year relapses just at the end of, or at the beginning of this year. So this is a frustrating but well-known situation that we've all been in. And so what are the next steps for somebody who had a FLT3 ITD mutation and actually progresses 2 years or at some time point after transplant? Well, the first is you want to recheck mutation status. Some people acquire FLT3 mutation, some people lose their FLT3 mutation, and then what other novel therapies can be considered. Now, this is older data. This is 5-year-old data. And it's looking at patients who were exposed to midostaurin, showing that you can lose your FLT3 ITD at relapse, and so that the clone at progression is not always FLT3 ITD positive. So the first thing you really want to do, this was almost half the patients in this analysis, lost the FLT3 ITD mutation. So you do want to confirm that they still have a FLT3 mutation. Sometimes they have the same mutation, sometimes they have an extra clone, sometimes it's a different clone, but that's an important question before moving on to a FLT3 inhibitor. And for somebody who's not had gilteritinib in the past, the Admiral study, the randomized study that led to the approval of gilteritinib, remains relevant. The longer-term follow-up was presented by Sasha Pearl at EHA last year. The median follow-up is 2.5 years now, and there's a continued survival benefit of gilteritinib versus salvage chemotherapy for patients who have relapsed FLT3 positive AML. The curves come together at about the 2.5-year point, as you can see. But when you looked at the long-term survivors, they were typically those who remained in remission, frequently proceeded to transplant, and received post-transplant gilteritinib. So an important message there that to be aggressive in that situation, try to get people to transplant in that situation, and if possible, even though it's not approved for this, try to use gilteritinib maintenance afterwards if it's available for that patient, pending the results of the MORPHO trial. And when you look at NCCN recommendations, it's really pretty straightforward. If they have a FLT3 ITD mutation, there's Category 1 agreement for the use of gilteritinib for both FLT3 ITD and TKD mutations. There is a role in some patients for other intensive therapy options, also for other targeted therapies if they have other mutations that are present at the time of relapse, an IDH1 or IDH2 mutation. We've recently published the role of gilteritinib even if you've been exposed to midostaurin in the past as an active agent in this setting, so something to keep in mind. So FLT3 inhibitors is a guideline recommended option, but what about novel combinations with FLT3 inhibitors? And the answer is there are novel combinations in development. This was also data that was presented at ASH in December using venetoclax and gilteritinib in combination at full dose in patients with FLT3 mutated relapse refractory AML. You can see on the left the composite complete response rate, or in some patients at least, morphologic leukemia-free state rate was almost 75%. That's regardless of whether they previously had a tyrosine kinase inhibitor or 60%, 6 out of the 10 patients, or sorry, it's 10 out of the whatever it is, 12 patients or 13 patients who had previously had venetoclax actually had a remission with the combination of venetoclax and gilteritinib. The median survival was about 10 months. The median duration response was about 5 months. But they measured whether you cleared the FLT3 ITD using a sensitive assay. And the patients who actually had a reduction in the allelic burden to less than 0.1 to less than 1%, pardon me, you can see that the median survival had not been reached. It's the green curve on top versus just under 7 months for the red curve down below. And so if you get this combination, if you clear the FLT3 ITD clone, you can get in some patients a durable response with the combination, even if they've been exposed to a TKI or to venetoclax in the past. Now, we've been talking about FLT3 inhibitors in a patient with a FLT3 ITD, but that's not the only situation where we have a possible targeted therapy option. And so what would change if we had an IDH mutation or if the patient was younger? For instance, instead of being a 66-year-old, what if this was a 35-year-old with a new AML diagnosis and normal cytogenetics and was transplant eligible and had an IDH1 and a DNMT3A mutation? Well, we would recommend a standard induction with 7 and 3 in most patients. The patient gets in complete remission, gets 1 cycle of high-dose ARC, and then still has a detectable DNMT3A and IDH clone at a lower VAF. So what are the next steps in this situation? Do you just continue consolidation? Do you immediately go to transplant? Do you initiate IDH-directed therapy? We know that there's some data of adding IDH inhibitors to intensive chemotherapy induction that was published last year from a phase 1/2 study that Eitan Stein published. We know that there are high remission rates. It's not a randomized study, so we don't know if it's better. But Dr. Barate, if it was a younger patient with an IDH mutation in this situation with detectable disease after their first cycle of ARC, how would that change your management, or what would you do for that patient?
So I think this is a discussion we have very often with our transplant colleagues because it makes us uncomfortable to see that IDH mutation and know that your patient is going to transplant. I think maybe when it's a myeloablative regimen and it's a low variant allele frequency, there's also the risk you don't want to delay the transplant too much to get to this perfect state where you don't see any mutations and it's a technically MRD negative CR. But if it's an older patient, it's a reduced intensity transplant, we do talk about potentially giving a patient a single agent IDH inhibitor to try to get rid of that IDH mutation. And we have done this for several patients where we felt that that is the best approach to give them the best outcomes post-allo transplant because they had an alternative donor or perhaps the conditioning regimen was just not as ablative as a true myeloablative transplant. I don't know if we have a lot of data in support of that. We do know from the VIALE-A study, even patients that have a CR still continue to have detectable IDH mutations and do really well. So I think it's clearly I don't want to say data-free zone, but data emerging zone. And we don't really have a lot of trials, but hopefully if we can get enough data from all our practices, we should be able to say whether this is what we would do as well. I don't know what you guys do.
Now, I like your suggestion. This is an area where we should probably try to combine data and see where the best way forward is. This is one where you don't want the perfect to be the enemy of the good. I agree with you. You don't want to delay getting to transplant, but we probably would also bias towards an IDH1 inhibitor, knowing that being MRD positive before transplant gets worse transplant outcomes. The DNMT3A really doesn't predict for much on its own, but I agree with you. We would address it, but we'd also be trying to work up quickly for transplant at the same time, certainly within 2 to 4 months if possible. So. Okay, well, I'm going to pass back over to Dr. Barate for evidence-informed choices pre- and post-transplant from maintenance to novel salvage.
Thank you. And so continuing in the theme of optimizing a patient for transplant and maybe optimizing a patient if transplant is deferred, and kind of what is the evidence to do all of these things. So now our patient is Robert, but he still is a 64-year-old newly diagnosed AML patient. However, this patient has intermediate risk cytogenetics and an NPM1 mutation. He does achieve a CR after standard induction. And the question that, again, we have a lot with our transplant colleagues is in this situation, should he pursue transplant in first remission or should he defer transplant? And if so, what is the role of maintenance in this type of patient? So again, sort of looking back at the NCCN guidelines and what is recommended for patients with intermediate risk cytogenetics and or other molecular abnormalities, including MRD positivity, usually if they're less than 60, the recommendation is a stem cell transplant with a matched or otherwise alternative donor, or maintenance therapy with oral azacitidine if transplant is not an option. So I think you have this sort of approach where you can potentially go either way, and I think the fact that this patient has an NPM1 mutation is even more valid. This patient happens to be over the age of 60. And again, if you look at the NCCN guidelines, they do have both options in patients that have undergone previous intensive therapy and have remission. I think the NPM1 mutation really confounds this discussion, because if you look at the NPM1 data in patients younger than 60, I think most transplanters advise that transplant and for CR is not necessary, that they could have very good long-term survival with high-dose cytarabine conditioning. There's a role of NPM1 MRD monitoring to predict which patients are high risk. But in patients with NPM1 mutations over the age of 60, I think the data is a little bit less clear because they're still at a higher risk of relapse, especially if they have other co-occurring mutations that could portend for a worse outcome. So looking at the maintenance data in this setting and why it's sort of an alternative recommendation to transplant, this was really prompted by the QUASAR study, which was a study looking at oral azacitidine as maintenance. And this was specifically in patients with intermediate or high-risk cytogenetics, not favorable risk, patients who were not eligible or could not go to a stem cell transplant, but they have to have had induction therapy followed by either 1 or 2 cycles of consolidation and achieved a remission. So patients were either randomized to oral azacitidine for 14 days versus placebo. And clearly this study showed an overall survival benefit of over 9 months in these patients and a relapse-free survival benefit for patients that got oral azacitidine versus placebo. I think the other thing that we learned, there was an additional long-term survival sort of follow-up that was recently presented. This showed that the overall survival benefit did hold up. But as you can see, as you get out to sort of that 4 or 5 year mark, the curves get really, really close together. And most of the patients that were on the study, even when they did get oral azacitidine, continued to show relapse as time went on. So we know that while oral azacitidine may delay relapse and improve survival, the question is that's not necessarily a long-term strategy for success. So I think there's clearly a strategy we can use in these patients, but whether it's the best or the right strategy, I think that's still an open question. So let's look specifically at NPM1 mutations, though, because this is where I think the rubber meets the road. And they showed in the extended analysis from the QUASAR study, when they looked at different mutational subgroups, the NPM1 patients did spectacularly better than any of the other patients. And they really derived the maximum benefit from this oral azacitidine maintenance approach. And here you could see that the overall survival was significantly improved in patients with mutated NPM1 compared to placebo, and the benefit was more than 2.5 years. So clearly in a patient like ours that we're discussing, this is something to consider based on the data that we now have from the QUASAR study. So in general, what are the challenges of this approach in a patient? So a reminder, giving somebody oral azacitidine for an extended period of time is not easy. There are a lot of side effects, especially GI, to remember. I still have a patient who's in their year 2 of maintenance that times her life around the diarrhea that she gets in the first few days of getting oral azacitidine, and she has an antidiarrheal regimen. So it's not something to say that, well, this will get better. It's something you really have to manage with the patient. The cytopenias are real. Some of the patients would need extended prophylaxis, and you always have to sort of watch for the extended neutropenia. You have to dose adjust and dose delay cycles depending on how patients are doing. So just recommendations, make sure your patients have adequate antiemetics and really follow their counts closely. So what do we do in the setting after transplant? So once patients have undergone transplant, this is data presented by Dr. DeLima from Ohio State, which showed that this is definitely an approach that can be done post-allo transplant. After 19 months of follow-up, overall survival was still not reached. This is something that is clearly doable at the dose of 200 milligrams for 14 days every 28-day cycle. And if you look at what data is emerging more in a randomized fashion, there is a phase 3 trial that was presented in Blood Advances of patients with high-risk MDS and AML that were either randomized to post-AZA versus observation and actually did not show a difference in relapse-free survival in these two arms. And however, there's another study with some conflicting data which did show that giving decitabine maintenance actually lowered relapse rate in the decitabine arm. So I think the data is conflicting, but as you can imagine in a post-allo world, what you consider high risk is very different from different centers, conditioning regimens that patient had, their post sort of allo medications and different regimens are quite different. So I think as with many of these studies, patient selection is a really big factor. So what about patients that received allo stem cell after AZA/VEN? We talked about, our patients, 10% of patients, older patients that were not eligible for intensive chemotherapy that get AZA/VEN and then go on to receive maintenance AZA/VEN, that go on to receive transplant versus just continuing on maintenance AZA/VEN after a response. How did they compare? This is a study presented by Dan Pollier. Now, this is an institutional look. This is not a randomized study or a prospective study. And what they showed is in their center, when patients received a response quickly to AZA plus VEN, and moved to transplant, those patients selectively were younger. You can see the median age is 65 versus 72. But look at the days from diagnosis to a transplant consult, and look at the days from the transplant consult to the time that the patient actually went to a transplant. I mean, this is a very big delay compared to how we're approaching patients that get intensive chemotherapy, where they're seeing a transplanter while they're in the hospital getting induction, they're being typed for donors. This is clearly sort of more of an afterthought approach that we all take because we've sort of determined these patients are not transplant eligible. So as AZA/VEN becomes more and more common, I think we really need to be alert that these patients actually could get a response quickly and potentially move to stem cell transplant. And then what happened? How did these patients do? And clearly, the patients that got the transplant early actually did the best. The patients where you deferred a transplant even after they had a response. So all of these patients actually got a good response to AZA/VEN, but the transplant was deferred, did very poorly. And even those that were not a transplant candidate but survived more than 60 days from diagnosis actually did not do well. So this is them taking away those early deaths and making sure they were trying to compare the patients as best as they could. So in general, for our patient, it does look like the data can support a maintenance approach based on the Quasar study. But I think it's an open question for patients over 60 with an NPM1 mutation. Let's say they have a co-occurring IDH mutation or a mutation that makes them higher risk. And this is a question I'd like to ask Dr. Foran. In this patient, what are your thoughts? Is this a patient that you think should pursue? You would highly, highly encourage stem cell transplant? Is deferring okay? Would you be okay with maintenance? And what if the patient had other co-occurring mutations that made them, more high risk than just NPM1?
Yeah, I agree with your comment on the co-occurring mutations, that actually would drive us more to a transplant strategy because the risk of failure is so high. But this is one where you really have to listen to the patient and make sure you know what risks they're willing to take and what works for them in their life. I've had that experience with oral azacitidine you mentioned, but I also have had people who, after the first 1 or 2 rounds, cruise through it pretty well. And I was struck by the data in NPM1 positive disease. In patients over 60, that's not so favorable. We've known that for 15 years now, unlike younger patients. I will say that this is a situation where you can do NPM1 monitoring so that most of us now, because of the IV data from the New England Journal a few years ago, would do molecular monitoring for NPM1 mutation every 3 months to monitor that patient for early progression and try to move in with a salvage and transplant strategy and if they do become positive. So I would be very comfortable with a non-transplant strategy in this patient. If that's it's not wrong to transplant them, but I actually feel that this strategy would make a lot of sense for them.
And how do you do your monitoring? Do you use blood and do you use NGS assay or PCR?
We do PCR. Assay? It's a patient-specific primers based. Not all NPM1 mutations are amenable to it, but it's patient-specific primers for that described NPM1 mutation that they have. And it's a PCR-based blood assay.
And it's from your institution or you send it out?
Yeah,
okay.
It's done institutionally.
Okay.
Yeah.
Well, thank you.
Yeah. Right, thanks.
Hand it back to you.
Thank you. Thanks. I was worried we wouldn't have enough time, but I think we're going to end up with 3 minutes ahead of time, so we're doing pretty well, because I think we both had a lot of coffee before we started. So what are the pre-transplant approaches in the salvage setting? This is a difficult situation that we all know well. Another case study, Margaret, a 72-year-old woman. By the way, at Mayo Clinic, we would call her Mrs. Smith, but a 72-year-old woman with treatment-refractory secondary AML. She has persistent disease despite low-intensity induction with decitabine and venetoclax. She still has a very good performance status, persistent pancytopenia, kind of a background dysplasia, about 8% blasts, and she actually has an HLA identical sibling. Now, whether I really want to use an HLA identical sibling versus an unrelated donor for a 70-year-old donor is a separate topic, but what is the role of a multidisciplinary hem-onc and transplant team collaborating and deciding on next steps for a patient in this situation? Well, I'm a member of the NCCN AML Guidelines panel, and this is a pretty sparse page in NCCN about what you do with relapsed AML. Get them into remission and get them to a transplant. That's really what these words are saying. Find some way to get a response, and if possible, maintain that response and get them to transplant. When you look at really focuses on targeted therapy, or chemotherapy as the options in this situation, and in truth, targeted therapy means a FLT3 inhibitor based on the Admiral trial, or the phase 2 data supporting IDH1 or IDH2. Obviously, there's also gemtuzumab, I suppose, as a targeted therapy, although not our preferred option very often. But what do you do when the treatment options are limited? One of the options might be lomab-B. I'm an investigator in this study. This is an I-131 murine monoclonal antibody against CD45, so it's I-131 apamistamab. CD45, what we used to call the leukocyte common antigen, is expressed in virtually all lymphocytes and the large majority of acute leukemias, both lymphoid and myeloid leukemias. And so the idea here is to use a monoclonal radio-labeled myeloablative antibody to target lymphomatopoietic cells with beta particle emitting radionuclide I-131. It offers, or at least it's meant to offer, target-specific ablation as a conditioning regimen for transplant, and it minimizes toxicity to other organs by focusing on lymphomatopoietic organs. You can see this is data from John Pagel in Seattle, older data now, but compelling data showing that you really focus this on the marrow, the spleen, and the liver, and you minimize exposure to the lung, the kidney, and total body when you give I-131 apamistamab, also called lomab-B. And so this has led to the phase 3 Sierra trial. This is lomab-B prior to allogeneic transplant versus chemotherapy in the relapsed refractory setting. A very innovative study, and actually this is a study that's completed accrual at the end of last year, and where we have some updates on the accrual at this meeting. This is for patients aged 55 and older with relapsed refractory AML, either primary induction failure after 2 cycles, early relapse less than 6 months, refractory to a salvage regimen, or second or subsequent relapse. You can tell this is a very difficult disease in those refractory settings to treat. You have to have a matched related or matched unrelated donor on the trial and have a Karnofsky performance status of 70% or greater. And the study was a 1-to-1 randomization of lomab-B followed by transplant versus conventional care, control arm chemotherapy. We had a list of standard available approved options that you could give based upon what that patient had had before and what might be appropriate for them. And it was a 1-to-1 randomized study with a primary endpoint of achieving a durable complete remission and secondary endpoint of 1-year survival. Now, if you got the lomab-B and you went into complete remission, you were followed up. If you did not go into complete remission, well, obviously you get supportive care or whatever other therapy is appropriate in that very difficult situation. One of the nice things about this study is it allowed crossover. If you were randomized to the control arm, all patients were cleared for transplant and had a clear donor before they were randomized. And if you got conventional care, after 1 month, if you did not achieve a remission and you maintained your performance status, you could cross over to the lomab-B because the primary endpoint of the study had been fulfilled. You did not have a durable complete remission. So this meant that patients had 2 cracks of getting to allogeneic transplant for refractory disease. And this is the treatment schedule of the patients who were randomized or crossed over to lomab-B. Patients got a dosimetric dose of the I-131 radiolabeled apamistamab. They had some imaging studies for biodistribution. They then had an individualized dose of radioactive antibody that was calculated to try to maximize anti-leukemic effect, but to minimize toxicity. So it took it up to 24 gray of liver exposure based on the biodistribution scans, and then you would individualize the dose to achieve that and maximize targeting of leukemia, of marrow, of spleen. Patients then got their therapeutic dose. They were in radiation isolation for for days, a few days until they were safe to be released. And once the radiation had dissipated, 12 days later, they initiated non-ablative conditioning with fludarabine and single fraction TBI, and a related donor allogeneic transplant with standard immunosuppression with tacrolimus and CellCept. Now, we had an update at this meeting. The study is 100% enrolled. These are the patients who've gone on the study. 153 patients have been randomized in this one-to-one. The median age is 65 or 66 years. You can see in the columns on the left are the lomab-B direct go into lomab and transplant arm. The one on the right, the 77 patients who got conventional care. You can see the array of cytogenetics, a little less relevant what your cytogenetics are once you have refractory disease. Nevertheless, they're balanced between the groups. You can see the disease status at randomization was also balanced between the groups. Over 50% had primary induction failure, about a quarter first relapse, about 15% had relapse refractory disease, and about 5 to 6% were second relapse or greater. And you can see the amount of disease that was left. Actually, there was a little bit of an imbalance here. Patients who got lomab-B had a higher blast percentage, 30% median, versus those who got conventional care, about 20% median. Of the conventional care patients, 40 ultimately crossed over after not achieving remission on protocol to lomab-B, and you can see their patient characteristics here as well. And they're very similar, with the exception that the blast percentage is even higher at the time of crossover. Otherwise, it's a very similar population who crossed over to get the lomab-B. Now, patients who went on to this study had received targeted therapy. This is a modern treatment study. They had received venetoclax. Of the patients who got the lomab-B prior to Sierra enrollment, 66% had received venetoclax-based therapy for a median of 3 prior regimens. Of the ones in the conventional care arm, half had received a targeted agent, but of those, 81% had previously had venetoclax. So this is a group who were refractory disease and, in many cases, venetoclax treated who went on to this study. And here are the results on engraftment and non-relapse mortality. So these are reassuring data. First of all, if you look at the lomab-B arm on the left, the median dose in millicuries was 650 millicuries versus conventional, well, 650 millicuries. The marrow dose was about 16 gray. The stem cell dose was about 5 million, 5.5 million per kilogram per patient. And you can see that most patients got peripheral blood stem cells, and there was a predominance of unrelated versus related matched donors. The time to engraftment for neutrophils, 14 days with lomab-B. Time to platelets, 17 days. All patients engrafted. There were no graft failures with lomab-B. If you look at the patients who actually got conventional care and crossed over to lomab-B, they had very similar results. A similar dose in terms of millicuries, a similar marrow dose of radiation, 16 gray, similar dose of stem cells in those patients, and a similar array of donors with peripheral blood stem cells and unrelated donors. You can see the time to engraftment is the same. 13 days for neutrophils, 17 days for platelets, no graft failures. So of the patients who got lomab-B, there was no engraftment failure, 100% engraftment, and patients were able to use this as a vehicle to get to transplant. You can see that not every patient who was randomized to lomab-B got lomab-B. It's about 85, 86% of patients. Some patients had early progression or something happened where they were not able to actually get the therapeutic dose, mostly disease-related issues, as a matter of fact, because this is a difficult situation. But of the patients who got to it, all of them engrafted. You can see in the far right-hand column the patients who actually, with conventional care, got a remission. 14 patients got a remission and proceeded to transplant. So that's less than 20%. It's about 18% of patients. They had a similar cell dose. They had similar time to engraftment, and 13 of the 14 had successful engraftment. And this appeared to be a safe conditioning strategy. If you look at the non-relapse mortality, it was about 9% for lomab-B. It was about 5% for those who crossed over from conventional care to lomab-B, and 2 out of 14 patients, just over 10%, with standard of care transplant. There was really no difference of patients who got lomab-B versus conventional care in terms of toxicity. The fever neutropenia rate was similar, certainly not higher, 35%. There was a statistically significant lower rate of sepsis, at 5% versus 23%. And then the rest of the toxicities of mucositis, pneumonia, et cetera, are very balanced between the arms. There was really no difference between other toxicities. So this is a well-tolerated, low incidence of sepsis with low non-relapse mortality rates and good engraftment. So that is a trial which is fully accrued. We're anxiously awaiting results. We're hoping those results are going to come later this year for that study to really show we know we can get patients to it, we know we can get patients engrafted. As an investigator in this trial, it was a lot of work on that trial. talking to nuclear medicine doctors is not something I was used to doing before the study, so that was its own experience. But we're anxiously awaiting results of that study. So let's get back to our patient, the 72-year-old patient, Mrs. Smith, Margaret, who had refractory disease and, but did have an HLA identical sibling. She had a refractory status. She had venetoclax exposure, making this a challenging case. And it would have been reasonable if she had been at our center when the study was open. We certainly would have offered her participation in this study. There are other salvage regimens after HMA venetoclax. It lists ven flag ida here, which is an aggressive strategy. But there are other palliative approaches, just that the response rates are quite low in that setting. And so there are alternatives for this, but this is a patient where we really need better therapies, and hopefully lomab-B will be a better therapy for a patient like this. Now, what if this case were a little different? What if instead of a normal karyotype, say, or an intermediate risk karyotype, this patient actually had a TP53 mutation? What would be the next steps, and would transplant still be an option? We know that patients with TP53 status, we've published on this ourselves from a multi-institution survey this year, that they do better with transplant than without transplant if you can get them to that. And we've known that since some data from WashU several years ago in the New England Journal. But we also know the transplant outcomes are very poor. Some older data from 2016 showed that 2 and 3 year survival in the range of about 10%. And some data presented at this meeting, a meta-analysis of over 460 patients from 6 separate studies who went to transplant, showed continued poor outcomes for TP53 positive AML with a 2 year survival of 15%. So yeah, it's better to get transplant than not, but the expectations are low. And this is a group where we really need much better therapies, and hopefully a TP53 targeted therapy or a better immune approach. Now, there are strategies in development. I won't go through the list of all the things that are being looked at. We've tried APR-246 and others to target TP53, and we're waiting for a better agent. There are studies of a CD47 blocking monoclonal antibody called magrolimab that may have efficacy in this setting. This is phase 1/2 data presented at ASH 2020 looking at azacitidine with this CD47 blocking antibody magrolimab in newly diagnosed AML. Magrolimab hits CD47. CD47 is an inhibitory signal for macrophages to prevent phagocytosis. So that if you can block CD47 and the downstream signal through SIRP-alpha, you actually enhance phagocytosis. And you activate kind of a novel part of the immune system we hadn't talked a lot about in myeloid malignancy, which is phagocytosis and macrophage-based phagocytosis. In the phase 1/2 study of magrolimab and azacitidine, if you looked at all patients, there were very high response rates. But when you looked at the group who had TP53, they maintained high response rates. And so there are now studies of azacitidine and magrolimab that are going on nationally to try to see if this is a strategy in patients with TP53 positive AML. So this is an area where we don't have an answer yet. We certainly have an important question, and we have studies in development.
And we do have a question about oral aza when it's time to.
Yeah, we can go ahead. We can go ahead and take that question.
So I think this is a great question, especially doing oral azacitidine in the setting of a post-allo patient where you want to use an oral aza maintenance strategy post-allo transplant. How do you assess GI, GVHD versus the toxicity from the drug?
Yeah, it's a great question. The data for using that's based on a relatively small study. It's a couple years old now. So we know we have an MTD. We know we have the dose that we think can be tolerated. But we don't have randomized data in the post-transplant setting yet showing that benefit. There are studies of HMA-VEN and other strategies, thank you, and other strategies of maintenance. Oral azacitidine is certainly going to be one of them going forward. And GI toxicity versus graft versus host disease is a really difficult one, and you end up doing extra flexible sigmoidoscopies for that one, I think. And so I think that's a very much of a balancing act for how you do an oral HMA that could cause enteritis or stomatitis in a patient who's had a transplant. It's a really great question.
And a follow-up question, just based on some of the comments you made about how you follow NPM1 mutated patients with MRD. So let's say you had that same patient we talked about, they were in CR, you were following MRD, and you see that it's now climbing. And at the rate that you think this is clearly, patient is going to relapse, however, a bone marrow biopsy shows they're still in a CR, what would you do then? Would you go directly to a stem cell transplant? Would you do another round of salvage and then go to transplant to sort of mop up the MRD? How do you approach that?
I'd love to hear your strategy in that situation, actually. That's a hard one.
We have debated long and hard, and in the end, it really comes down to what the transplanters feel comfortable with and what that MRD level looks like. I think most transplanters want to give a round of something, but they don't want to give something too intensive that makes the patient, sick and ends up in the hospital with neutropenic fever and delays transplant. So typically we've done, a cycle or two of aza-ven or something to help sort of bring down this MRD. Again, not data-driven, but to sort of optimize the patient as they go into a stem cell transplant, as that donor is sort of being worked up.
Yeah, I completely agree with that. It really depends on what mutation you're monitoring. If it's NPN1, it's a bit like learning, it's a bit like the weather showing you the tornado right before it hits your house, right? I mean, you know the tornado's coming, but you still have to seek shelter, and you don't know what's going to happen. But it gives you an opportunity to try to treat. We would give something if we could. If I want to do an emergency bone marrow transplant, that's still 8 weeks, even if I have a donor lined up. And so I would try to move quickly with that, but I agree, we would be repeating it in a month, we'd be getting a marrow, we'd confirm it, we'd get on some therapy in the meantime, because you want to go in with as little disease as possible. But that's not an easy situation.
Yep.
Yeah. A question did come through, by the way, in the standard of care arm, was the preparative regimen myeloablative or reduced intensity or non-ablative? Actually, it's non-ablative. They had, patients received a potent anti-leukemia therapy with lomab-B or radioimmunotherapy to ablate their marrow and actually target their disease. And they then get a non-ablative transplant with fludarabine and single fraction total body radiation. Now, it may be that something else is better. We don't know that yet. It may be that a post-transplant maintenance is better. We have to see the results of that trial and build upon them. But right now, it's designed to be a myeloablative conditioning, kind of with lomab-B, but a reduced intensity fludarabine single fraction TBI. And it asks if the donor stem cells are exposed to lomab-B, and that's a really important question. There was a 12-day period between getting the radioimmunoconjugate and starting the non-ablative conditioning for that very reason, to make sure that there was no or minimal residual radioactivity in that patient so that stem cells would engraft. And as you saw, it's reassuring everybody engrafted. So I think that schedule is right, and we saw 100% engraftment. There's a question here at the microphone.
Yeah, that was my question earlier about the intensity of the preparative regimen. I was more looking at the standard of care, the non-IOMAB arm, if they also received a non-myeloablative.
Oh, I'm sorry. I actually don't remember that. They got a standard of care transplant. And so that could be whatever transplant was appropriate for them. These were patients aged 55 plus, so I actually don't know that. I think the majority got a reduced intensity conditioning. They did not get non-ablative transplant in that setting. There's kind of a debate about ablative versus non-ablative for somebody who's 60 and fit, which is a legitimate question. But that was a standard of care transplant. The non-ablative was only for the patients who had the lomab-B. Yeah.
Speaking of conditioning regimens, there was a question from the poly data that I discussed when patients get aza-ven and the patients at their center that ended up going to transplant. The question was, what was the conditioning regimens that those patients got after getting a CR from aza-ven and went on to transplant? So I actually had to pull up the paper because there were so many different options. So if they had a matched sibling donor, they got a variety of either busulfan cytoxan type conditioning regimens or flu-mel or flu-TBI based regimens. If they had cord donors, which actually about half the patients had a cord or even a haplocord, they received more of a cytoxan, fludarabine, thiotepa, radiation sort of combination regimen. So there's several different conditioning regimens depending on the donor that were listed in that paper.
Who would have thought that transplanters would use so many different regimens just based on the day of the week? That's not like us. We're at time now. There are some other questions. If there are questions in the room, we're happy to address them. I know that there are people following this virtually as well. But I want to thank you for getting up early, and thank you for your attention, and also thank the sponsors and also the funders for the opportunity to do this educational activity. So thanks very much.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HJG860. This activity is supported through educational grants from Actinium Pharmaceuticals, Astellas, and Bristol Myers Squibb.